Hi, I am Dr. Shabana Umar Siddiqui, a consultant sonologist and the director of Dr. Shabana School of Sonology. Today I am excited to share a new video with you which is about pelvic pathologies. Today our topic of discussion is ovarian pathologies. Ovaries are almond-shaped structures. Its normal size varies with age and parity. It is located in adnexa or anywhere near uterus. Follicular development in reproductive age is divided into three phases. Number one is follicular phase, in which multiple small follicles, that is less than 10 millimeter, are there. Number two, dominant follicle, in which 18 to 25 millimeter diameter follicle is there prior to ovulation. Number three is corpus luteum, which forms after ovulation, and it is thick-walled with peripheral ring of fire on color Doppler scan. Functional cysts. Number one, follicular cyst. It is anechoic, thin-walled, and unilocular. 3 centimeter but less than 8 centimeter. Usually it regresses spontaneously. Number two is corpus luteum cyst, which is thick-walled and crenulated margins. Peripheral vascularity is there, ring of fire on color Doppler scan. It may contain hemorrhage, internal echoes. Then is hemorrhagic cyst. It is variable in appearance depending upon the stage of clot. For example, it may be reticular, which is fishnet pattern of fibrin strands with no internal vascularity on Doppler, and it usually resolves within 6 to 8 weeks. Endometriomas or chocolate cyst. Homogeneous low-level internal echoes which gives a ground glass appearance. It has a thick capsule with minimal vascularity. It may be multiple or bilateral. It can be associated with pelvic adhesions or endometriosis. Benign ovarian neoplasms are of two types. Number one, serous cyst adenomas, which are unilocular, thin-walled, and usually anechoic. Then is mucinous cyst adenoma, which is usually multiloculated with fine septations, and it is usually large in size. Dermoid cyst or mature teratoma. It is mixed in echogenicity. Echogenic Rokitansky nodule with acoustic shadowing of hair, teeth, or fat is there, and it gives an appearance of tip of an iceberg sign. Now we'll talk about malignant ovarian tumors. The suspicious features of malignant ovarian tumors are thick irregular walls, papillary projections, solid components, ascites or peritoneal deposits, high vascularity on Doppler, low RI, and high PSV. Examples are epithelial ovarian carcinoma, which is most common. Then is germ cell tumors and sex cord stromal tumor. Polycystic ovarian syndrome or PCOS, in which ovaries are enlarged, that is more than 10 ml in volume, and peripheral arrangement of multiple small follicles is there, which is called string of pearls appearance, increased stromal echogenicity, and clinical correlation with Rotterdam criteria. Ovarian torsion, in which ovaries are edematous with peripherally displaced follicles. There is a whirlpool sign of twisted pedicle, absent or reduced vascular flow, but not always absent, and it's a surgical emergency. Role of Doppler in the diagnosis of benign and malignant lesions. In benign lesions, there is low or no vascularity, while in malignant lesions, irregular vascularity is there with central blood flow and low resistance index. It helps in differentiating cystic versus solid and benign versus malignant. Let's discuss about uterine pathologies now. Uterine pathologies are congenital anomalies, fibroids, adenomyosis, endometrial pathologies, and cervical pathologies. Congenital anomalies of the uterus. Congenital uterine anomalies occur due to abnormal fusion or resorption of Mullerian ducts. They are important because they are associated with infertility, recurrent pregnancy loss, and obstetric complications. The types of congenital anomalies are: number 1, arcuate uterus, in which there is mild concavity of the endometrial cavity, usually normal fertility. Septate uterus, thin echogenic fibrous or fibromuscular septum dividing the cavity, best seen in coronal plane on 3D ultrasound. Bicornuate uterus, 2 endometrial cavities with a deep fundal cleft, may show 2 separate endometrial echoes. Then is unicornuate uterus, small elongated uterus deviated to one side, may be associated with rudimentary horn. Then is didelphys uterus, in which there are 2 completely separate endometrial cavities and endocervical canals. Uterine fibroids. They are benign, smooth muscle tumors, most common uterine pathology. They are estrogen dependent. Prevalence increases with age until menopause. Ultrasound findings: well-defined solid hypoechoic or heterogeneous mass within the myometrium. They may cause uterine enlargement. Types of fibroids are submucosal, intramural, and subserosal. Submucosal, protruding into the endometrial cavity. Intramural, within the myometrium. Subserosal, projecting outward from the uterus. Calcification may appear as echogenic foci with shadowing, and degenerative changes like cystic, hyaline, or red degeneration also occur. Doppler scan typically shows peripheral vascularity. Adenomyosis. Adenomyosis is the presence of endometrial glands and stroma within the myometrium. It is associated with dysmenorrhea, menorrhagia, and infertility. Ultrasound features of adenomyosis are diffuse or focal uterine enlargement, heterogeneous myometrial echotexture, ill-defined areas of low echogenicity, myometrial cysts, thickened junction zone more than 12 millimeter on MRI, and asymmetrical thickening of anterior or posterior myometrium. Endometrium. Endometrial pathologies. Endometrium is highly dynamic, influenced by hormones. Ultrasound evaluation should always be cycle specific. Common pathologies of endometrium are endometrial hyperplasia, which is thickened endometrium, heterogeneous echotexture, and it may contain cystic changes. Endometrial polyp, focal, well-defined hyperechoic lesion within the endometrium. Feeding vessels seen on color Doppler, pedicle artery sign. Then is endometritis, thickened irregular endometrium with increased vascularity. Cervical pathologies. Ultrasound is valuable in evaluating both benign and malignant cervical conditions. Common findings are Nabothian cysts, small, simple, anechoic cysts within the cervix. They are benign and common. Then is cervical polyps, focal echogenic lesions protruding into the canal. Then is cervical fibroid, which is well-defined hypoechoic solid mass within or protruding from cervix. Cervical carcinoma, heterogeneous mass replacing normal cervical stroma, distortion of canal, and increased vascularity.